Hi everyone, my name is David Villar. I work as a professor of pharmacology at a university in Colombia. Welcome to this presentation on local anesthetics, which are a group of drugs that should be included in most protocols to provide analgesia. We're going to see some examples of different applications of local anesthetics. And for the most part, we could say that their value is largely underestimated, as they can provide almost a complete analgesia with very little or no side effects. These are really the only drugs that totally block the transmission of noxious or painful signals into the spinal cord, and by doing so, they are going to prevent the process of central sensitization, and pain will be easier to control when the patient wakes up from an anesthesia. On the next slide, we're going to review some papers in which they use local anesthetics for each one of the applications listed here. The first one, infiltration. This is when we provide an incisional blocks, and because sometimes we need relatively high amounts of the drugs, we combine them with epinephrine, so we prolong their duration of action and also prevent some of those local anesthetics going quickly into the bloodstream. Now, a splash block is when the drug is directed to the site of interest, let's say a root canal for a tooth extraction, or for example, adjacent to an ovarian ligament for ovariohysterectomy. The next one, field blocks. These are the typical C-sections in cows, and when these are done correctly, we basically block the nerve tracts that innervate an entire body region distal to those the line of the injection sites. With regards to topical anesthesia, here the drug must be capable of penetrating either through an open wound or a skin or a mucous membrane. This is the typical lidocaine creams that are used prior to placing an IV catheter on an animal. Another application is epidural anesthesia, and this involves the injection of the local anesthetic into the space surrounding the spinal cord. And supposedly the site of action are those spinal nerve roots, but maybe some of that drug can also diffuse into the spinal cord itself and have additional effects that way. And finally, we can use the local anesthetics to provide analgesia with systemic infusions, and these are usually combined with other analgesic drugs like opioids or ketamine. So the first example in which they use incisional blocks with bupivacaine in dogs undergoing celiotomy or laparotomy, if you like that term better. This study involved 60 dogs that were randomly allocated into 4 groups. One received preoperative bupivacaine before the midline incision. Another one received postoperative before the skin closure, and these 2 were compared with 2 controls given preoperative or postoperative saline. Now, all the dogs received the opioid meperidine, and the conclusion of this study was that the preoperative bupivacaine was associated with significantly lower pain scores, and they used a numerical rating scale, and they also found that there were significantly lower need for opioid administration in the postoperative period. Now, a concern that maybe some veterinarians might have is that the local anesthetics delay healing, and that's not really true. They don't really affect healing of the wounds, of the wound site. Now, if we move on to another study, this one again reinforces the concept of giving the drug before the surgery, and also the using different ones to attain a multimodal enhanced effect. In this case, the positive control was using epidural administration of morphine, which nobody probably uses for male castrations. And in this study, the 2 groups that received epidural morphine or intratesticular bupivacaine had lower postoperative pain scores than the groups that received the combination of injectable opioids and then non-steroidal carprofen. So we could say that because the pain impulse was completely blocked in the intratesticular group, the brain did not realize that the spermatic cord was being crushed, And crushing injuries are really very painful and probably the most painful stimuli of any type in surgeries. So even the intratesticular group on this study was superior to the epidural injection of morphine, which is kind of a gold standard, because they found that there were less number of dogs that required rescue analgesia, and they also had lower pain scores and level of cortisols released after the surgical procedure. Now, on this next study, they evaluated the effects of maxillary and alveolar nerve blocks in cats undergoing dental extractions. All the cats received systemic buprenorphine, medetomidine, and acepromazine, and they used a composite pain scale before and for 4 hours following the extraction. The results were that the pain during and after the extraction was much lower in the group receiving the local anesthetics. During the surgical procedure, the heart rate, blood pressure, and minimal alveolar concentration of the gas anesthetic needed was lower in the group with the local anesthetic. And this is obviously an indicator that the animals were not feeling as much pain during the surgery procedure. Obviously, even if we don't use local anesthetics, all those cats are going to feel better after 3 or 4 days without those painful teeth. But the question is that in the meantime, they're going to be quite painful. So this type of studies, again, reinforce the idea of the importance of providing as best preventive analgesia as we possibly can. Now, another interesting application many veterinarians may be unaware or unfamiliar with is using local anesthetics diluted 1-on-1 with saline to irrigate the peritoneal cavity in dogs undergoing a ovariohysterectomy. In this case, they instilled a local anesthetic, bupivacaine, after the surgery was completed. And obviously, they were comparing these animals to a control group that also received opioids and non-steroidals. And the bottom line is how much basically you are enhancing the analgesia by giving these local anesthetics in the peritoneal cavity. This is actually widely used in human medicine, and in this case the conclusion was that the bupivacaine, which is longer lasting than lidocaine, provided significantly lower pain scores compared with the saline or the lidocaine group. And this is something that is usually not contemplated in most ovariohysterectomies protocols, and as you can see here, it is an application of the local anesthetics that veterinarians should probably be doing more frequently. Now, one of the issues with infiltration anesthesia is that sometimes very high amounts of the local anesthetics are necessary, and if they were to be absorbed very rapidly, there is always the risk of creating toxicity. So you may come across formulations that combine the use of lidocaine with epinephrine, and on this study they look at the impact of adrenaline on the kinetics of lidocaine injected into the paravertebral brachial plexus, which you may need to do if you were to amputate the front leg of this dog. So they injected 8 dogs with the usual 2 milligram per kilogram of lidocaine at the spaces of C6, C7, and the junction C8, T1. And then they collected blood to measure the concentration of lidocaine for the next 3 hours. And what they found is something similar to what you might see on this graph, which I took from another study, and I just wanted to illustrate the point of flip-flop kinetics here. When adrenaline is combined with lidocaine, the absorption rate of lidocaine is prolonged, so you don't really reach such high concentrations in a short time, and consequently there is less potential for systemic toxicity. And in addition to being safer, you also prolong the duration of action of that local anesthetic, because the lidocaine is going to be at the site of injection much longer. So as you can see on this graph, the decline or the elimination part of the concentration curve is less pronounced with epinephrine, because the lidocaine is being slowly absorbed from the tissues. Now, another way to look at the multimodal effect of analgesic drugs is looking at how much uh, isoflurane is necessary during an intervention. And in this study, they use a combo of lidocaine and ketamine and compare it with each one given alone. And as you can see on the lower graph, the combination of the two drugs decreased the minimum alveolar concentration of sevoflurane by 62%. And also notice that both drugs were initially provided as a bolus, and then they were followed with a constant rate of infusion, CRI. And this is done to keep concentrations steady during the entire anesthetic period. Now, on this other study, they use a computerized pressure algometer to determine pain threshold in dogs that were subjected to a pressure stimulus. And the idea was to determine which concentrations of ketamine and lidocaine will raise that threshold level. This was a crossover study with 6 dogs, and the 3 groups were given a bolus of ketamine, followed by a CRI, or a bolus of ketamine and lidocaine, followed by CRI of both drugs, and a group with a bolus of ketamine, followed by a higher rate or dosage of ketamine given CRI, 50 micrograms per kilogram per minute instead of 30 micrograms per kilogram per minute. So if we look at the results of this study, they found that the minimum serum concentrations of ketamine that produce analgesia are between 100 and 200 nanograms per milliliter, which is similar to what has been found in humans. But unlike humans, dogs need a higher constant rate of infusion of ketamine to achieve those concentrations. So this is kind of a good example why you cannot always extrapolate doses from one species to another. And at the higher CRI of the ketamine, the dogs develop some of the anesthetic effects of these drugs, like disorientation, swaying of the head, salivation, hyperactivity. And the most interesting thing was that bringing lidocaine on board with the lower doses of ketamine not only produced similar nociceptive thresholds as the higher concentrations of ketamine, but it also prevented the side effects of ketamine. So basically the analgesic effects were very short-lived, and they disappear within 20 minutes of ceasing that CRI. And that's one of the reasons why they need to be constantly infused. So if we were to reach a conclusion on this study, we could say that all the 3 treatments increased the mechanical threshold for pain, and therefore they provided anti-nociceptive effects or analgesia. But when lidocaine was introduced or combined with ketamine, they needed lower concentrations of ketamine or dosages of ketamine. So the bottom line is that a multimodal approach is always better to control pain, and it's going to have less side effects because you don't need to use as much of each one of the drugs. Now, as a final slide, there is some controversy as to whether lidocaine should be used in cats or entirely avoided. It seems to have a bad reputation, but when you search the literature, it doesn't really suggest any particular sensitivity of cats compared with other species like dogs. The rationale is that constant rate of infusion of lidocaine causes more pronounced cardiovascular depression than an equipotent dose of isoflurane, and also that normal doses used in infiltration and blocks could potentially kill a cat given if this was given IV. And this is not really the case if you don't really exceed the therapeutic doses, which are usually below 10 milligrams per kilogram. Now, if we look, for example, at this one study that they compare the central nervous system and the cardiovascular toxicity of lidocaine and bupivacaine in cats, They were infusing really a whopping dose of 60 milligrams per kilogram per minute until the mean arterial pressure reached 10 millimeters of mercury, and they call that the cardiotoxic endpoint, at which point they started a resuscitation protocol, and that I must say that that protocol was successful in all the 10 cats that were used. So the conclusion of this study that was that the mean convulsive dose of lidocaine was 12 milligrams per kilogram, which is about 3 to 4 times lower than the cardiotoxic one. In other words, you may see tremors and convulsions or seizures before you see major changes in heart function. Now, if we look at a more common scenario in which you use lidocaine as an IV bolus and you follow it with a CRI, which is what was done on this other study, they found that lidocaine causes a dose-dependent decrease in isoflurane requirements. And as you can see, they went from a steady concentration of lidocaine of 1 to 10 micrograms per mil, which is really what we want to achieve as part of a balanced anesthetic technique. And at the higher concentrations of the 10 micrograms per mil, there was a 59% reduction of the minimal alveolar concentration of isoflurane that was needed to anesthetize those cats. And an interesting thing is that when they look at the electroencephalograph recordings, they found no activity suggestive of scissoring or convulsion in those cats. So now the problem is that you need to lower the concentration of isoflurane if you're going to use lidocaine, because if you don't do so, that the combination of both the lidocaine and the isoflurane will definitely cause severe cardiovascular depression, and you would basically have to discontinue giving both and initiate some supportive measures. So it is important to keep in mind that if you plan to use typical isoflurane concentrations, you may want to avoid using lidocaine by CRI. This was my final slide. We have kind of covered a lot of information in a very short time. I hope you enjoyed the presentation. So until next time, bye-bye for now.